Okay, good evening, everybody, or afternoon, or different times of the day, depending on where you are. I'm Harry Hoyen, and this is the next in line for our Hand Essentials series. This is Articular Fractures of the Hand. You can see a few particular cases over there on the right. Go ahead, Glenn, next slide. We have some great faculty today. I'm very happy. Glenn Gaston's going to give us our talk he's from Carolina. I'm Harry Hoyen. Jeff Lawton was involved last week as well. And we have Becky for hand therapy from Baltimore. So it's a great lineup. Next slide. These are the disclosures which we have resolved. None of them in particular will be influenced or pertained by this talk. Zoom etiquette, please. If everyone would mute their microphones and your videos are turned off, please use the question and answer box. And Jeff, myself, and Glenn will be fielding questions throughout the talk. Go ahead. Articular fractures of the hand. It's important to identify which fractures will require surgery. We need to also understand some of the surgical approaches, as they are very particular depending upon finger, thumb, etc., and really recognize some of our strengths and weaknesses and the impact on function and range of motion of the individual's hand. Next. These are a couple of little teaser cases. This is a PIP fracture dislocation. Next case. Gentleman with a gunshot wound. Go ahead and show the slide there. Articular fracture in addition to some other involvement. Go ahead, next one. 17-year-old struck a helmet playing football, and a very different articular fracture. So we can sort of see three different fractures. Go ahead, next slide. Now this is some of the forces on that fracture, which will be explained towards the end. We'll come back to these. And Glenn, go ahead and kick us off for the talk.
Great, thanks, Harry. All right, so why even have this talk specific to just articular fractures of the hand? And there's really, I think, two reasons we wanted to highlight these. One are that the results of articular fractures are simply inferior to those of extra-articular fractures. And there's several reasons for it, but one of them is the importance and difficulty in healing hyaline cartilage appropriately. So that's why we want to focus on these particular fractures. So here are the examples that we're going to discuss tonight. So we've got articular fractures of the hand. We got to consider metacarpal head fractures and metacarpal base fractures. And then we have phalangeal base and head fractures as well. The base fractures tend to be avulsions and shear fractures. And the head fractures we can classify as unicondylar, bicondylar, or at times diaphyseal with extension into the joint. And then we also have fracture dislocations, which Harry showed us a case of, and those can be volar dorsal or what we call pilon fractures involving both sides of the joint. So to treat articular fractures successfully, there's 5 principles I'd like to really drill home tonight. One is that for the majority of fractures, we really want anatomic articular reduction. There's a few exceptions to that I will discuss. Secondly, we need to correct the axial and rotational alignment of the digit. And then thirdly, we need to provide stable fixation that will enable us to do early range of motion, which our therapist Becky will really stress to you as well. We need to choose the right timing for surgery, and we need to choose the optimal approach to surgery. And if we do all these, we can indeed achieve success. Now, once upon a time, the rest and prolonged immobilization was believed to be essential for bone healing, and this persisted in much of the 1800s. It wasn't until following that all of a sudden the recognition that prolonged immobilization was bad, and it led to what they called this triad of fracture disease, of stiffness, pain, and functional disability. And it was Perkins who really first said that most of the disability that occurs following a fracture is related to the treatment and not the pathology itself, and that he believed prolonged immobilization was harmful and the patient should be encouraged to move despite the disease in these joints and the pain and discomfort. And that's really what led, of course, to the foundation of AO. And Sir John Charley said, perfect anatomical restoration and freedom of joint movement can only be obtained by simultaneously internal fixation. So in speaking specifically to articular fractures, the reason this is important, as I alluded to, is the articular cartilage. We know it's resilient, elastic, and it's avascular. And if you look at it, we're not going to go into the articular cartilage biomechanics in detail, but just remember it distributes forces very evenly across the joint. It provides a frictionless joint surface, and it serves as a shock absorber. But when it's injured, it's extremely sensitive to injury, and it's got healing potential, but it's limited. And it really requires a perfect mechanical environment to heal well. And small incongruities are well tolerated, but larger incongruities are not. And cartilage, just as a reminder, it really thrives in compression and it fails in shear. And that's the principle of basically every orthopedic periarticular osteotomy, from the hip to the knee. Everything we do is trying to place cartilage out of a position of shear and into a position of compression. Anatomic reduction was the first point I wanted to make. And this is some of the old slides by Salter that really highlight that if you look at this joint, if it's fixed just slightly off, we see fibrocartilage is what it heals with. And when it's fixed anatomically, we see a much more hyaline-like cartilage that's formed. So having that reduction as anatomic as possible is critical. We can see in this slide, when we have a joint step off that heals that way, we see the cartilage thickens on the depressed side and it thins on the more pronounced side. And this occurs even with just 0.5 millimeter of step off. And whether or not you immobilize or mobilize the joint does not affect this phenomenon of cartilage healing. So if you look at the contact pressure when cartilage heals off, the contact pressure is 3 times elevated on the prominent side and 40% less than normal on the depressed side. So anatomic articular reduction is going to be the key overall. But the hand's a little different. We do know there's areas we can get away with not everything being anatomic. The DIP joint doesn't contribute as much to the total active motion of the digit, and we'll see that mallet fractures can tolerate more. Fractures that have less articular involvement, fractures that have a congruent joint and minimal to no impaction, we can oftentimes get away with a non-anatomic reduction. And there's been some areas that we've seen, mallet fractures, volar plate avulsions, and some collateral ligament avulsions can still heal quite well and function well despite not being anatomic. Mallet fractures, just as an example, it was historically taught that if there was more than 30% of the articular step off or any subluxation, it needed to be fixed. But then that more recent literature has really challenged that. Now, if we look at prospective randomized studies, we can see that there's no difference between fractures that had more than 1/3 of the joint involved if they were pinned versus if they were simply placed into a splint. Taking it one step further, we would certainly think a fracture with subluxation would do worse. However, the data doesn't necessarily seem to support that. Fractures that are more than 1/3 of the surface, even with joint subluxation, did equally well to those that were managed non-operatively. So should we fix these? If you look at the meta-analyses, insufficient evidence to determine when surgery is indicated. So while anatomic articular alignment is the goal, it may not be the case for every single fracture. But for the majority of the ones we're going to focus on, that is our goal. And when we approach these, there's a balance we have to strike. If we make a larger exposure, we get better visualization. If we use strong implants like plates and screws, we can get more fixation and it makes us feel as though we might be able to rehab the patient more aggressively. However, it comes at a cost, and that cost is more soft tissue disruption, higher risk of blood supply to the small fragments, and an increased risk of adhesions. So I think my take-home overarching principle for the night when it comes to fixation would be consider the least invasive approach that you can do to attain reduction, followed by the least invasive implant that's capable of maintaining a reduction to allow early range of motion. Axial and rotational alignment must be corrected. As we know, if you have increased force over a smaller area, that increased stress is going to wear out the articular cartilage faster. And in the case of the hand, patients will often struggle with digital overlap. So again, this axial alignment will dictate the cartilage loading condition and affect cartilage healing. And digital malrotation interferes with the function of the adjacent digits, not only the involved digit. So we need to correct the axial and rotational malalignments as we approach these fractures. What about early motion? We've known ever since 1980 the importance of this with some of Salter's early data looking at CPM versus immobilization on cartilage healing in a rabbit model. Look at these right here, 2 great images. This is what it looks like when you create an injury in a rabbit and you immobilize them. And this is what it looks like when you put them in CPM with the same thing. So we know that early motion allows cartilage to heal better. So that simply has to be our goal. Joints immobilized for more than a month are going to be stiff. Joints that have open reduction and internal fixation plus immobilizations are going to be even more stiff, versus simple traction and early motion, as that middle image shows, you can oftentimes achieve a very good overall outcome for the patient's motion. And then ORIF plus early motion can oftentimes yield even the best possible results. So stable fixation and early range of motion is critical. What about the timing of surgery? Well, certainly all of us know that there's a window of opportunity that tends to exist immediately following injury. Oftentimes, this allows for evacuation of hematoma, reduction of fracture fragments, and preventing further bleeding, and allow earlier resolution of soft tissue swelling. Some more significant injuries can have soft tissue swelling, such as you see here and here. They're going to lend itself much more poorly to intervening at that time. So primarily, we tend to have less edema, good skin, and it's a good time to operate. There sometimes is a primary deferred window, however. If the soft tissue trauma does not seem to be optimal at that time, then splinting, bracing, or spanning external fixator temporarily to allow those soft tissues to heal and that envelope to be better to go back for more definitive fixation. So we're going to certainly respect the timing of surgery as we come through these. And what about the optimal approach for these fractures? From terms of the beginning with the metacarpal heads or the MP joints, a dorsal approach is the approach that we most commonly use. And how we're going to manage the sagittal bands is really the only question. And there's two options. You can either split the extensor tendon or you can release one side. And if you're going to release one side of the sagittal bands, my recommendation would be that you release the ulnar side. Remember, because of the vector that they run, it would be extremely uncommon to see symptomatic radial subluxation of the sagittal bands, whereas symptomatic ulnar subluxation is more common. We certainly see it in rheumatoids, and you can induce it in trauma as well. So personally, I like to split the index and small fingers because there's two tendons and there's a very natural plane. And I prefer to go through the ulnar sagittal bands on the central digits. Once you've addressed the sagittal bands, it's a dorsal capsulotomy. And then with joint flexion, you usually have adequate visualization of about the dorsal 2/3 to 70% of the joint. And then when I'm fixing metacarpal head fractures, as you see here on the right, my strong preference is to use rigid fixation such as headless compression screws. If that's not possible, then K-wires and or pins can be utilized. What about the PIP joint? Most of your central slip avulsions, phalangeal head fractures, and the rear pilon can be addressed through a dorsal approach. Typically, that's made with an incision between the central slip and the lateral bands, as you see in the image on the left. At times, you can go volar to the lateral band and retract the lateral band and central tendon both dorsally to expose one side more. That's also a useful deep window to use if you're doing a lateral approach to the digit. And with that dorsal approach, we can address fractures such as the central slip avulsion. Untreated, this can lead to a boutonniere deformity. And with a dorsal approach, we can get right down on it, rigid internal fixation to allow early range of motion and maximize outcome. A bit tougher fracture here. This is a pilon fracture. We see a large displaced dorsal fragment and palmar fragment. This is one that oftentimes I'll use a dynamic external fixator if I don't think I can fix it. However, in this case, two pretty large fragments and the dorsal fragments displaced fairly significantly. So a dorsal approach lended itself nicely in fixation with a small locking plate, as you can see here, allowed the patient early range of motion and an excellent outcome. And then what about the volar approach for PIP fractures? This is very helpful for volar shear fractures and for many of our dorsal PIP fracture dislocations. This is what's called a shotgun approach to the joint, where we're going to make a Brunner incision on the palm of that digit. And then deep, we're going to make a cruciate window from the distal edge of the A2 to the proximal edge of the A4 pulley. The flexor tendons can then be retracted to the side and the volar plate released off its distal insertion. And then with subsequent hyperextension, we can deliver the joint to be seen directly, and we can make a direct anatomic reduction and fix fractures with either two screws, as you see here, or what's also becoming popular are small plates, sometimes something known as just the Seattle seatbelt, which is just a 2 or 3 hole plate across the front that stays very proximal in its nature, such as not to interfere with the FDS insertion. And this is what that shotgun approach looks like. You can see the flexor tendons have been retracted to the side. The joint has been hyperextended while the volar plate has been released. And what do we do about fractures that are just non-reconstructable? We simply don't have the bony architecture that we're able to address. In the end, with those fractures, we basically have four options. One is to bring them a new joint, an osteoarticular reconstruction. And that's what we see on the image on the right. This is called a hemihamate arthroplasty. We can take the dorsal aspect of the hamate, and you can see the ridge centrally that would separate the fourth and fifth CMC joints, or fourth and fifth metacarpal bases. And you can then size and carpentry that to fit nicely, and it makes a very nice fit for reconstructing the base of the middle phalanx. Option two is we can do an interpositional arthroplasty. And Jack Tupper popularized this quite a long time ago. And honestly, it's one of the things that doesn't get talked about much, but I'll show you a nice little case of that in just a moment. And then we can either replace the joint, either partially with a hemiarthroplasty or a total joint arthroplasty, not something I do often in my own practice, or we can fuse the joint. So here's an example. This was a 19-year-old kid with a gunshot wound, took out his third metacarpal head and portion of the diaphysis. Then distally, we still had the volar plate attached to the base of the middle phalanx. And so initially, a little what's called a mascale technique of an antibiotic temporary spacer was utilized. And then 5 weeks later, the patient returned and we took an iliac crest bone graft, shaped it to look like a metacarpal, and then simply interposed that volar plate between the head of the new metacarpal and the base of the proximal phalanx. And that's called a Tupper arthroplasty. And in this case, and in my experience with those, you can end up with about a 50 to 60 degree arc of motion that's typically not painful. Again, partial or total joint replacement for non-salvageable joints is an option, not something I have a lot of experience with personally. And then lastly, fusion. Here's a bit of a challenging case. You can see an industrial fan has taken out the radial 3 digits, the head of the metacarpals down to the diaphysis, temporarily spanned with an external fixator. We were able to do primary ORIF of the small finger, and then return with a large end block iliac crest graft that's able to be primarily arthrodesed to the 3 MP joints with subsequent extensor tendon reconstructions, and a very acceptable outcome, at least for the nature of this particular injury. So I'd like to move us into kind of summarizing the things that I think from a principle standpoint are key when dealing with articular injuries. Number one is for the majority of these, particularly metacarpal head, metacarpal base, and then the head of the phalanges, and then our fracture dislocations of the PIP joint would be one where articular surface anatomic alignment may not be as possible. And then stable internal fixation, but again, less can be more in these finger fractures. There's times where we'll see some cases coming up where a simple dynamic external fixator accepting a little bit of articular malalignment and not quite as rigid as plate and screws may be preferable, certainly in terms of the functional outcomes. The importance of restoring that axial and rotational alignment, and really critical, probably the most critical thing is being able to do early range of motion for these to achieve really the optimal outcome. So some of these cases we have now, I'd like to spend a little bit more time with to really highlight some of the principles that we just went over, and we'll use the cases to highlight that. And then we also have a section we're going to speak about as to the critical importance of the therapy in managing these fractures. So Harry started us with this one, and Harry, I'll let you chime in as well. This was a 17-year-old struck on the helmet playing football, and he's got a baseball scholarship. Harry, you want to describe this case and walk us through it a little bit and highlight how some of the principles we talked about can be employed?
Yeah, so this is a, and the reason we put this is it's football season now, and with COVID, everybody wants to get into games, and one of the hardest things, and I think Jeff and Glenn will talk about this a little bit, is that when can you let someone go back to play, and how should you let them go back to play? But this is a base metacarpal fracture, and in this particular instance, he's a linebacker, so he came in like this, onto the helmet, which is interesting. And this represents a base metacarpal fracture, probably a bit of a dislocation to a certain extent. You can still see pretty reasonable alignment on the view on the left there, but there's some articular involvement in it. And as Glenn had pointed out, most of these fractures involve other parts, whether it be the metadiaphysis, whether it's up into the shaft. And I would for sure recommend really good x-rays, even tracks from fluoroscopic views to see other parts of the bone. We get pretty involved onto the metacarpal side. Glenn, do you have a pointer there to point over onto the right image there, further there? Some of their, highlight some of those articular pieces there. So there's a central piece, and maybe one screen over there too, one image over there. Look at, there's one over on that radial side there, and then there's that sort of classic, let's say, Bennett fracture fragment that it contains the anterior oblique ligament. Maybe because classifies as a quote Rolando fracture in this instance, but sort of a C2 or 3 in the AO classification. Jeff, anything else that you look at on these sort of things? And these are some of the forces for those that have to take some tests coming up for the OATE. The APL is certainly pulling on this proximally with the EPB. There's rotation from the thenar muscles, and then the adductor pulls the proximal part of that with the aponeurosis towards the index metacarpal.
Yeah, I agree. I think it's sort of a Rolando's variant. I mean, you definitely see intra-articular involvement and displacement. So, based on Glenn's talk, we want to get the articular surface anatomic and then sort of hang that anatomic joint on a diaphysis. The metadiaphyseal component is a little bit flexed. Obviously, that's the least of his problems. So I think, getting the joint perfect, and then, some kind of a T-plate or a little diamond plate that's got a few more fixation options proximally. So for these, you could think about either like a Wagner approach or just a straight lateral approach, depending on your preference.
Yeah, we should talk about that a little bit. Go ahead. I think I have one fluoroscopic image on the next slide.
So a traction view is really handy to help make some plans. The other thing that some people will do is get a CAT scan pre-op. I'm not sure that that's necessary, but if you like to think about the fragments and think about your fixation strategies a little bit more, that may be helpful. But I think this traction view is actually more helpful to me than a CT scan. Yeah,
those are my little fingers in there pulling, and you can see I'm pulling a fair amount because the MP joint's distracted. Right, so it's getting a bit of a tug, little hands, big tug, and it also looks like there's some joint, especially on the one on the left over there. There's a little bit of joint subluxation too, so it's a bad actor here.
I agree. Another thing, just when you're thinking about CMC joint mechanics of the thumb, I would point any of y'all, if you haven't read some of Ollie Edmonds' work, he's out of Louisiana, has really written a lot on the important stabilizers, the ligamentous stabilizers of the CMC joint, and the reduction maneuvers in what he calls his screw home torque mechanism of how to deal with these. So Ollie Edmonds has some nice papers I would point you to for that. I agree, Jeff. I think a CT would show you that it's more common than you guessed it is. But I think you'd find it out in the OR as well. For me, approaching these, the one tool to have with you when you do this surgery is a dental pick, because what tends to happen is that volar piece, the so-called beak ligament and the beak piece of this, it's usually sitting where it's supposed to, but it's hard to get the shaft to it. So you can hook it with a dental pick and really hold it firmly against the dorsum, which tends to have the larger articular block, and then put the pin into it. That tends to be the best reduction instrument for me personally.
Yeah, this is so, guys. If you were to, if the plate is, let's say, going to be on the tension or dorsal side. So often I'll do a dorsal approach, as you can see on the next one. But some of that articular involvement is volar and ulnar. Mm-hmm. So, Jeff mentioned the Wagner approach, but Jeff, if you do that to get down to there, first of all, it is a bit of a dissection. Then you just have a flap dorsally for plate application.
Yeah, then you just extend it up to get your plate on.
Yep.
And then, so with these, I'll sort of piece the joint back together, as Glenn said, sort of that dental pick, and sort of reach around that fragment, bring that fragment in, stabilize it without stripping that anterior beak ligament. And then sort of a pin cushion of K-wires. And then often you can lay the plate over one or two of those K-wires, get non-locking fixation distally, and then go back and replace your K-wires one by one with screws through the plate, lock screws through the plate.
So this is I did a little bit of a dorsal approach on this one. Glenn, how often do you like the Wagner approach? I find that it's a lot of dissection to get down there, and sometimes it's even hard to see.
Yeah, for the simple ones, I tend to go more just straight dorsal like you did here. For the ones that I think I'm going to struggle with my articular reduction, I have found it helpful, and I'll extend it, just kind of bring it palmar at that border of the glabrous and non-glabrous skin, of course, and just raise that thenar muscle kind of in a proximal to distal direction and get right down. I think it's easier to get the articular reduction when I extend it there versus straight dorsal. It's very, very hard to get any of the palmar pieces reduced, at least in my hands, quite as well.
Yes. So what I did here is that trying to do a little Capangee technique to bring that articular surface down with a small K-wire through the fracture. And I'm always impressed on how proximal that dorsal fracture exits, right? It goes down a ways right next to that one screw, that anti-glide screw, but it goes all the way to the edge of the joint. And I think that, and then go to the next slide there, that beak ligament, I thought real good about it. And then I said, oh boy, look at that. So I'm off, right? On that corner. And I kind of hooked it like you guys did. I had more of a dorsal approach. I didn't necessarily complete the Wagner approach, but kind of took the dental pick up underneath the thenar with a small little slit. And I realized that might be two different pieces there. So it's close, but not there. Go ahead to the next one. So what I did here was to try. Yeah, next slide. Yeah, what I tried to do is to work from inside the fracture a little, as Jeff did, and I use those screws to raft down to try to push that beak ligament down. I know Glenn, you were saying or Jeff saying the beak ligament doesn't move much, and I think the main fracture fragment moved, but there was something in between those two that was still. Go back to the other slide. Right where that open hole is in the middle. No, go back.
Yeah. So you can kind of see it right here.
Yes, that guy. Right, and so.
Little snake.
Little snake. So it got pushed down, and as you can see over on the right, there's a bit of a void there, but that now I have those screws into there. So someone asked why the K-wire, right? It's a little 3.5 K-wire or 1.1 K-wire, very small. And I've had a couple of these because of the way the fracture exits, and I'm trying to grab that beak ligament way back here. I've had some where the joint just decides to drift away on me.
Yeah, I agree. I have a low threshold for a few weeks pinning the CMC joint.
Yep, that's exactly what I did. Just a couple weeks, and I try to go through the little beak ligament piece if I can get it. You can see on the right there, I couldn't quite get it. The screws kind of blocked it, so I'm in that sort of somewhat depressed piece. But I use very small K-wire in these instances. It almost. I'm almost I'm amazed sometimes when I take it out, it's a little bent, which means that it was under force, even though he's in a cast. And we'll talk about rehab. What do you do after 3 weeks? I think I got a post-op. This is a fresh case I just did. And this is the day I'm going to take the K-wire out. And I think if you look, let me minimize this for a second, over on the right, which I never even saw, he also had a trapezial fracture. Right at the bottom of that K-wire. You can't see it there, but I took a couple other x-rays. It's sort of a little split in the trapezium, which I never even saw from the original ones. Go back. You can see there's one maybe on one little shadow. There it is. Yeah, right there. Yep. Maybe, but I thought that might have been the edge of the metacarpal coming around, but yep. So the K-wire served two purposes inadvertently, right? One to hold his joint. So, this is for me and for the audience that don't forget, these are articular. So there's a subluxation dislocation component in addition to the articular segment, in addition to the metatarsal. And you can see that how this goes up almost into the shaft where that first screw was. And so all those principles in one little thumb case, which is pretty common. So the inevitable was, as soon as the K-wire comes out, can I play? And I said, absolutely not. This is tiny fixation in this instance. It's soft callus. I guess if you're a lineman sort of thing, but I said, you would kill yourself because you have a baseball scholarship. You want to play your last football game. What are you thinking? If something happens, it's hard to hit a ball. It's hard to catch a ball. You need a really gracile thumb. to do this. I said, this is a hand-eye coordination sport. So I did not let him play. But if this was something, Jeff, you're taking care of these, and so are you, Glenn. So the K-Wire comes out at 3 weeks, when can they participate?
Yeah, I agree,
Jeff,
Harry.
Jeff,
I would be a little bit hesitant on this too, because if you think about your fixation in that ulnar segment, you're trying to hold on to it from the far side, and all it is screw threads and cancellous bone. I mean, even if you do have that cortex, it's just thin periarticular cortex. So I agree. I wouldn't want him landing on that thumb. I mean, if he was a lineman and could play in a cast, I'd probably be inclined to do that. But like you said, his main interest is in baseball, so I think I would counsel him as you did to hold off.
Yeah, I do the same in this case. Elite athlete, protected play I would probably allow at this time, but it's not his main sport, and I would do the same thing. I would hold this kid out.
If he's a like a wide receiver and he's on the pro team there or whatever, how long do you? Because it's certainly soft. If he lands on this hard, it's going to go crunch. You wait another couple of weeks, wait to 5 weeks.
Yeah, especially because they can't play protected very well. You can kind of hard tape them for their thumb and leave the MP joint free. I'd probably let that roll around 4 to 5 weeks is when I'd probably let them play. Lineman or someone like that, elite, I'd let them play at around 2 weeks when the sutures were out.
Yeah, for infection purposes, that's very important. Yeah, go ahead.
Yeah, discussion is germane to sports. But let's say this person was not a sports person, and you were in the OR, and your modular handset fell on the floor. Now what are you going to do?
Clean it, flash it, and use it. But no, I guess if it's gone. We talked about this a little bit. This is, you could provide some K-wire fixation in this instance, so that stabilize the joint with the 1 K-wire. There it is. Jeff alluded to K-wires across the articular segments to hold them, and then utilizing the index finger as a internal X fix for me. The K-wire from the thumb metacarpal to the index metacarpal.
And do you see a role for using external fixation? I mean, I know you said you're not going to use the CT routinely, but let's say you had a CT and by chance you happen to have some allograft in the room, or you're able to harvest some bone graft. Would you be able to fix it alternatively for people who may not have the ability to have modular handsets available to them?
Yeah. External fixation is either into the trapezium, or you could even go into the wrist area. I prefer not the wrist. I think K-wire fixation is probably reasonably sufficient, because neither can get early motion, and you have the index metacarpal as an internal bar to a certain extent. And I have used external fixation. We have a case coming up for a different area for external fixation. But I would probably use the K-wires in a similar fashion.
Yeah, I agree. I think if I was going to do it that way, Chai, and I didn't have this option, if I was going to do an X-fix in this case, I would actually do a quadrilateral X-fix where you go from the index to the thumb, and you can really maintain the palmar abduction of the thumb. The problem in this particular case is that impacted fragment. So I think even if you only had K-wires, I would probably do open anyway, just to get the impacted fragment back down, even if I was fixing that with small K-wires and backing up the fixation with a quadrilateral X-fix.
Exactly. So that's precisely the point I was trying to make, because in some situations, some of our audience may not have access to some of the fancy stuff, hardware that we use, but they do have access to external fixators. And the other thing I was alluding to is using threaded K-wires. You can use them like little headless screws and cut them off flush, and they work remarkably well. So something to think about.
Yeah, I agree. The only caution with threadless K-wires, if you're going to leave in here, is make very sure you get a lot of good x-rays during the way, because it's very easy to cut those off and then get a different view, and it's actually more prominent than you think, and it's sticking out somewhere you didn't want, and then they're hard to retrieve.
I agree. So the beauty of threaded K-wires is they can be inserted like headless screws, but you have to insert them at really low torque because they advance very quickly. And before you cut them, you want to take multiple views before you cut them flush, because once you cut them, there ain't no going back.
Yep. All right. We've got about 25 minutes left. You want to let Becky run her talk on the therapy side, and then we've got about 4 more cases we can discuss at the conclusion of that. Becky, you want to unmute and take over?
I'm unmuted. Can you see me? Okay, so can you hear me?
I hear you.
We can hear you, but we can't
Wonderful.
see you.
I don't know why my camera's not working, but anyway, I'll proceed. So in general, for therapists, we need to know how stable the fracture is, how it was repaired, and any other structures that were repaired in the procedure. That's really helpful to know, so we know what to protect, and also to be aware that there could be potential dysfunction at uninvolved joints, like for instance, in the wrist, a DRUJ problem after a distal radius fracture. So you want to think about all these things, and also it's helpful to know this information so you can do the appropriate timing for range of motion. If you feel like there should be any restrictions in their range, that's a good thing to let us know. And you know, it's always a balancing act between providing enough protection but applying controlled stress for motion and strength to enhance healing. So the first things we want to address, you know, with all hand injuries and hand therapy is providing adequate edema control and pain management. That's critical so that the patients can be comfortable and comply with doing their home program. So we provide orthosis for protection, and then as therapy progresses and there's more fracture healing, we might be doing something to improve motion, some sort of static progressive splinting if needed. And then, you know, advance the exercise prescription, advancing from active assistive and active range to later on, after there's more fracture healing, to doing some gentle passive range. And then some patients may require ADL assessment and training, and it's good to do a baseline sensory eval and do desensitization if needed, and then they progress to functional activities and strengthening. So next slide. One of the, this was a great article, and it stressed the importance of getting all the fingers moving early in the hand to provide edema control, which is, I think, more effective than having the patients do Coban wrapping. So we want to immobilize only the digits we have to, and also, you know, get all the fingers moving, have the patients perform active ab and abduction. And if there's no contraindication, you can activate the deep venous system by performing resisted adduction. So that's a great technique. This one I wanted to show because although she wasn't a fracture, I have to admit, this woman had replacement MP arthroplasties and centralization of the extensor tendons, PIP capsulectomies, and extensor tenolysis. So this was her presentation about 5 days post-op. I was pretty concerned about the, you know, ecchymosis and the swelling. And next slide. Started kinesiotaping, which I'd never done that early before, and it's just amazing how quickly it helps resolve the bruising and the, you know, boggy edema. So just be careful not to put it over the sutures, because that could be irritating when they move. But next slide. This is how she looked 4 days later at her next therapy visit. So I'm a big believer now. I'd used it before with elbow fractures to help resolve the ecchymosis, and it just works really great. And it's easy. The patients, you just put it on once, and they don't have to keep reapplying and changing it. So I'm a big fan of that for edema control post-op. And the next slide. So with Dr. Brand said it best, and I think this picture says it all. It shows just how many different gliding parts there are over the proximal phalanx. The extensor system wraps around 75% of the bone. So it's really important with all hand fractures to get, you know, the joints moving early, especially the PIP. It does not like to be immobilized. And as one of our doctors says, it can't take a joke. So the next slide. So this is taken from Roz Evans' original article on early short arc motion, which is a protocol that she developed. And they based it on providing 30 degrees of PIP flexion causes 3 to 5 millimeters of glide of the central slip. And so this study it was used for central slip repairs as well as complex injuries with fractures. So it was compared to traditional immobilization group for, 6 weeks of immobilization. So the significant findings were there's a great decrease in the extension lag at discharge, double the PIP motion at 6 weeks, and greater motion at discharge. And they were also discharged earlier. So this is a great technique, and it's pretty simple to do. Next slide. There's also, this shows you the splints that you would use if you had a central slip repair. So if you're doing it for a central slip repair, you need to know if the lateral bands are involved. If they are, you want to limit the DIP excursion in the DIP block. And then if they're not involved, they can do DIP motion within their pain tolerance. But you splint the finger in extension in between exercises, and they have these little template splints to show them, how far is 30 degrees, excuse me, of the PIP. And then you advance it by about 10 degrees each week. So that would be for repair. If it's just a fracture and you want to use it to get them moving early, you might not have to limit the excursion, but it's helpful too if you have an overambitious patient for them to have a template splint if you have a certain set point that you want to follow the first couple weeks. And there's also a great review article by John McAuliffe. If you want to read the short version, like the Cliff Notes of Roz's work, his article was published, I think, in 2011, and it's good. So now we can go. So one of the complications with metacarpal fractures and proximal phalanx fractures can be a PIP flexion contracture. And you could have both limited active PIP extension, and you could end up with a flexion contracture that needs to be addressed. So moving things early helps to prevent that problem of adherence. And it's particularly important with proximal phalanx fracture, as I said before. So next slide. And then you can use different types of splints to address the adherence. This would be, I put in the wrong picture. So for the ring and small finger, that would be a relative motion extension split. So if you need to support the joint in extension so you're not overstretching it and getting a greater lag, you could do that. And then later on, if you had a PIP extension lag, you would use the relative motion flexion splint, which puts the MP in flexion relative to the other fingers. So that's a great little splint, and it should be in all our therapists' back pocket, as Dr. Lalonde would say. And next slide. You can also do static progressive splinting. MP joint contractures, I don't think occur as much as they used to, because people aren't immobilized as long, and also we don't have to put them in as much MP flexion as or extension as previously. So, but this is just an example from Hannah Gift about a static progressive flexion splint. Next slide. So one of the complications with distal phalanx fractures can be numbness, hypersensitivity, but more frequently cold intolerance is a big problem. And I usually tell people that, it's usually the most severe the first year. Just get some good gloves, get something, or try using mittens, but it should gradually get less severe over time. And one thing that patients are frequently concerned about is the nail deformities. So with sagittal band injuries, or if you've done an MP, say you did an MP head ORIF and had to split the extensor and you wanted to protect it a little bit, you could use this relative motion extension split, which is pretty much what we use for acute sagittal band injuries and sagittal band reconstructions. And so that's what we're using post-op. And I think that's it for my slides.
All right, we'll keep rolling into the cases then. We also had a couple of questions. You want to hit those first, Harry? You want to keep rolling through the cases?
Why don't we do the questions at the end?
Okay.
Okay. Yeah, maybe we'll do one more case and then we can kind of do some questions. Jeff, you can take a look at them, and Glenn, to see if they pertain to some of the cases we're doing. I put this one in here, and this one I really want to get some opinions on. And this is a gentleman, and we actually have a fairly, oddly enough, in Cleveland, a big group that plays cricket. I don't know if Troy's still, on, but they get there's no mitt, so it's tough if you get hit or you try to catch the ball. So we had two guys back to back the same week. One guy was the sub for the gentleman that got hurt the first week. This is the sub. So This is a tough little case, small finger, PIP, fracture dislocation, as you can see here. And Glenn, what strikes you on this one is sort of the blink, like, oh boy, I really don't, I'm not interested in, in this referral.
The heavy sigh really comes with that dorsal cortical breach in addition to the fracture dislocation. So now we've got not only a pilon fracture with the dorsal and palmar cortexes intra-articularly involved, but we've got a significantly depressed central fragment, comminuted centrally, joint subluxation, probably already some wear on the head of the proximal phalanx. So it's definitely a heavy sigh when it rolls into the office.
Yeah, I like that. I'm going to use that heavy sigh. So you had a great case that you showed where there was dorsal exposure, and it was a fracture on the dorsal and the volar aspect. And I've tried that in a couple of instances with dorsal plate fixation, angular, fixed angular stability, and I've had the volar piece drift away on me. It doesn't stay as a whole. So this one's a little more comminuted, but walk us through a little bit when you choose between, let's say it's plate fixation, volar, or dorsal in these instances.
Yeah, to me, that case was really unique because it was just two large articular fragments. Anytime you've got these comminuted impacted pieces, the ORIF in my hands is not going to work for very many pilons at all. That the case I showed was the exception, not the rule. To me personally, this is not one I can piece back together.
I was all excited because I was going to maybe try it next time. Yeah.
Yeah.
Okay.
No, I think it works for. I think if you have
Kyle,
two big.
What do you think about this one?
This one in my hands. Oh, go ahead.
Yeah, I mean, you can look at it. So Harry's sort of, like you did your traction view, I'd have a couple different options going in, and I'd tell the patient, the default is an X fixed, a little mini X fix, and, there's different styles that you could use. I think I would take a look under traction and see if that dorsal piece and that volar piece sort of wanted to come together, and then that little 4-hole locking plate like Glenn used, I've used that as well.
Do you like it from the dorsal side, guys? There, or you showed one where you had also some volar fixation as well.
Yeah, I don't think this one's going to come together with that move personally. Now, you could try, in addition, the Strouch technique. Bob Strouch just tried placing a K-wire directly through the flexor tendons and into that small palmar fragment, and then you can use it as a little joystick and drive it out the back. I wouldn't argue against a limited little small dorsal approach to put that fragment back down, the dorsal piece, with either a small screw or a K-wire. But for me, probably this is going to get a dynamic X fix. One of the principles I touched on is there's times you just can't get perfect articular alignment. But what you really want in this is joint congruity. So as long as the PIP joint's congruent and we don't have that dorsal V sign, I think you're going to be okay in terms of getting at least an acceptable outcome. So dynamic X fist plus or minus a dorsal blocking pin for me would be my approach for this one.
Got it. All right, so let's go to the next slide.
Drawing.
There we go. So those are, we should have had those. So those are the things we talked about, non-operative, all those things. And in this instance, plate fixation, X fix, hamate. Oh yeah, someone always asks, and mention this. Why not a hamate reconstruction in this? We know.
Well, you'd have to have that dorsal piece united. So, I mean, I think as a bailout, if your X fix, if the volar part sort of melted away and you got subluxation into that, you didn't have the concentric reduction that Glenn said. Somehow, at least if you get that dorsal piece to heal, then I think you could always go back and then do a hemi-hamate once that's healed. But you need that dorsal piece.
Got it. And I think that's the key in there. And everybody asks, when the hamate, you have to have a dorsal buttress to attach to. It's got to be intact on that dorsal side. So here we went pretty low tech. This is actually a TB syringe cut off on each end, and with the K-wires, one in the axis, and then a second in the proximal phalanx, and then two into the middle phalanx. And it seems easy, but it's a little harder than I sometimes anticipate. And what I do for these is just straight for 2 weeks, and then I remove the proximal K-wire and allow for some motion around the axis. So go to the next slide there. And it reduced fairly well. I was pretty happy, and it's amazing. And this is what you were talking about, this resorption, Jeff, this dissolution of some of these pieces. And so here he is in a couple of weeks. And I felt really good. And you can point out, go back one, Glenn, you can see that little hole I missed on the first K-wire in the middle phalanx there. Okay. So see, sometimes you line these up and you got to make sure you get all these in the right place. So then I removed, and I for some reason I couldn't find the funnels, but then I went, go to the next slide. I removed the proximal K-wire and allowed for some motion. And this is when I'm going to take the whole thing off. And even a little bit of motion, look what it did to my articular surface, right? I just lost a little bit, and you can see that central impacted fragment in the center part, and on the middle X-ray there, pointing out there's that little articular, or maybe subchondral area, but he has good congruity on the AP. It's really good, right? He's not tilted one way or the other. And his, minus some of that vein of the central part of where I lost that impaction, his middle phalanx cortex lines up with his proximal phalanx cortex down the intermedullary canals. So it's what Glenn talked about. And he obtained fairly reasonable range of motion by rotating around this axis pin here. So here's a really low tech technique. And, we could show some other ones of using the rubber bands or the K-wires around the hooks. And I haven't had great success with those. And I use this on occasion, not very often, maybe a couple of times a year, but it's a reasonable bailout. And it actually looks good when you use the TB syringe and you cut off both ends with the nice little calibrations. It looks like it's something you designed because it has the nice numbers on there, and the patients are okay with it.
Hey, Harry,
Guys,
this is Kyle. Can I ask a question?
Yes.
It's, as everybody has alluded to, this is a really challenging fracture, and I don't think that in anybody's hands you're going to get a perfect articular reduction. But I wondered why you chose a static X-fix and not a dynamic X-fix, in hope that you could maintain traction longer while you're mobilizing the joint, because I think, it's pretty clear that you were trying to walk a fine line between keeping this immobile long enough that you get it sticky enough that you can move it, and not holding it immobile too long so you end up with a locked in cemented joint. Yep. And in my hands, the only way I can really walk that line with any success is if I allow them to move as early as possible and use a dynamic fix. Again, would it have led to a much better articular alignment? It's hard to tell, but I think what happened was it just wasn't sticky enough, and when you let it go, it kind of collapsed.
Yeah, probably a little bit. This has some traction built into it, because when you put it on, and then this then moves, because it moves around that, all these involve the bone moving on the K-wire essentially in the end. And in this particular instance, he can move. So in a couple of weeks, he moves here. And you're right. It's probably a dealer's choice. I try to put a little traction on this. It doesn't have a lot of traction because the joint's not necessarily distracted. But go back one slide. I probably had a fair amount there. You can see it's quite out the length. But if you look carefully, I think the main thing is that volar cortical piece, that little rim, is a bit vertical. Glenn, point that out right on that. Okay.
Right. That's
still vertical. I didn't quite get that down into place, and that might have helped a little bit. The dorsal piece is quite good. So are you using the dynamic X as a rubber band, or the one where you bend the K wires around the middle phalanx?
Yeah, I do the Slade fixator with the rubber bands, and I actually have a diagram of that I keep in my briefcase. So it's always in the OR with me, because, you have to look at it pretty carefully to make sure you bend everything exactly the right way. It's a pretty intricate little mechanism, but, it seems to work. I'd like to also mention one other thing, which is that it's only when you get this finger out in traction that you can appreciate the size and configuration of these fracture fragments. If you go back to the initial films, everything's impacted and it's exploded and it's rotated, and you can't really appreciate how that joint might come back together. And so I will take them to the OR, get them prepped, and then apply manual traction, just, pulling on the finger digitally while my assistant is holding the wrist to give a stable fixation point, and look at it carefully under fluoro. And And in this case, I might have opted for open reduction internal fixation because I think both the dorsal and the volar fragments, which are your two main articular components, are big enough that you can put a small screw or two screws from dorsal to volar, across there and get a pretty good articular alignment. And in those cases, you do a shotgun approach, you bring that impacted articular surface down, you pack a little bone graft behind it. And I've been happy in a number of these cases at how carefully I can reconstruct that joint. When initially looking at it before you expand it, it just looks like it's exploded and nothing's going to come together. So I would never, give up hope until you're absolutely sure that that's not going to work, because then you can really mobilize the hell out of these things once you get rigid fixation.
Kyle, when both those
Again, these are terrible
when,
fractures, and
yeah,
and it's never perfect.
Yeah, when both of those are disconnected from the shaft after you place the screws, eight to P, sort of volar to dorsal or dorsal to volar, how do you link the shaft to those pieces? With a plate, a
Yeah,
fixator?
in that case, I would probably put a tiny little fixator spanning it from the proximal phalanx over to the shaft of the middle phalanx and hold it for maybe 3 weeks while you let the joint start to get tight. And then you can take off that fixator, you can get them into therapy with splint protection and get some very early gentle motion once you've got a little bit of connection between that reconstructed articular component and the shaft.
Yeah, that reduction, now that one that we got
Just
there was pretty good.
Another way to go about it. Yeah.
Maybe that would have been the time, go back one Glenn for me, maybe that would have been the time for those small little threaded K-wires or a little screw there, because that's a pretty good reduction there for sure. Kyle, that's a great point. Mixing and matching, right? Just because we're going external fixation doesn't mean you add some other things to it.
Yeah,
I think these are great
Thanks,
cases.
Harry. Great case.
Good. Yeah.
I agree. Yeah, it's definitely one that in my hands, every one of these ends up getting considered for CRPP versus XFix versus ORIF versus hemihamate if it's not the Pelon version. So I think it's a long discussion, and I think you're right. Mix and match, and each one of these kind of has to be its own personality.
Okay, great. Let's go to another case. This is completely changing gears. So it's an accidental discharge of a weapon. He is a Jamaican gentleman. He's actually a fantastic guy, has a job. He flips homes, makes all his appointments, et cetera, and he presents here. And I'm like, oh boy, another heavy sigh. So it's viable, it's sensate, unfortunately, right? I say that unfortunately because the decision gets made pretty easy. And I said, boy, I don't know if this is reconstructible. And he said, no, I want to keep this finger. And he showed me his elbow, which has probably a total arc of about 100 degrees of range of motion from another type of injury that didn't work well. And he was okay with, like, look, it doesn't move, but I have it. So just the static X fix in this instance. And I tried to stay out of the zone of anything else I'm going to do. So a terminally threaded chance pin in the hamate, one in the ring finger base metacarpal, and then two into the proximal phalanx. So, and it's also a bit of a test of time. Can you take care of the pins? Can you do the right thing? Can you get the wound to heal, et cetera, et cetera? And here he is at about 6 weeks of dealing with this. And the pins are pristine. They're like shiny. Here, okay, now a little further, 2 months. Soft tissue is okay. I was going to ask everybody what we're going to do, but in the essence of time, I also recommend maybe this is not reconstructible, because it's really not going to move, is it? I mean, it's really, there's no articular surface left.
Yeah, so I mean, this is a talk
Jeff,
about articular, and there's no articular, so it's not really
there's a few pieces.
Yeah,
there's a few
they're
pieces
floating
there.
around. Yeah, so I mean, I think that an X fix is a good technique. I mean, I either would think about bone grafting it acutely if you think you can get it clean. If you can't get it clean, I probably would have put a dowel, a cement dowel in. More for two reasons. Number one, for a little bit of masculé, if that's the direction you're going to go with cancellous bone, but to reserve your space for your eventual reconstruction, because when you go to put in a big piece of iliac crest, you're going to find that if you haven't sort of reserved your parking spot, that it's all filled in with scar tissue, and then you're sort of cutting through that and peeling it out and sort of filleting out unnamed tissue planes. So I like to have a piece of cement in there, and that way when you take it out, that's where your bone graft goes.
Yeah. Okay. Yeah. Good point. You know, and then
And then the question is what's the long game in terms of is this going to be a fusion or Glenn sort of mentioned, and I similarly have minimal experience with a surface replacement arthroplasty into that iliac crest graft if you want to give them a joint. Obviously it's not going to be a tremendously durable joint, but it gets them a little bit of motion.
That was sort of the thought. It's a point is, as I said, to build something, to create some sort of canal again, to create some sort of whatever, find the pieces that you have. And you can see there on the fixator holes in the proximal phalanx, they were wobbling around and they needed to come out with a little bit of osteolysis there. But the bed was reasonably clean. So iliac crest, small plate, to just build something to give them, let's say, a stable post on the post-axial side of the hand.
Yeah, Harry, this is another one too, that if the volar plate's still there, what you can do, leave it attached distally and you can bring it through that space and then suture it to the dorsum. And that's that Tupper arthroplasty I was alluding to. And that's what I've used for gunshots where the metacarpal head is gone and I've still got that volar plate, is you just use it as an interposition and it's still attached distally and then you sew it to the dorsum and it gives you a little something to glide around. And to me, it seems to get them some motion at least. So
yeah, I'm not even quite sure what that piece was. I tried. The hardest thing about this is for me, it was getting the proximal phalanx shaft. It's somewhat in relation in translation to his metacarpal.
yeah, I think that's where that helps if you can get that piece. And
Hey, Harry.
Yes.
Just to be devil's advocate, would you ever consider doing an allograft versus the technique described by Anam Kaur and Julie Buchler, where they took a metatarsal head?
or autograft, Chai.
Autograft, yeah.
Autograft of metatarsal head, which is what Kaur and Buchler described, and allograft is what Henry Mankin used to advocate.
Yeah.
Yeah, I don't know. I mean, it's the difficulty here is the extensor mechanism isn't awesome. The flexor has had a bullet go through it to a certain extent. So I think the motion is going to be limited, and this is I think, as Glenn says, a bit of an interposition. I was actually thinking of something probably prosthetic later. I've done some allografts for other parts, and they incorporate okay. The cartilage kind of dies, and I've been average at best. I've tried it.
Yeah, it's like I said, devil's advocate, but the only autograft would have been a metatarsal head. So.
I mean, he healed this, and I actually thought about doing something else later on. And he came back. And I said, "Mind if I take some pictures?" And he says, "Okay, I'm gone. I'm good." And he has very, very almost no motion, but he's not mal rotated. And for him, as you can see with his jewelry there, it's very important to have this in the sitting position on the table. This looks like a hand. So it's just throwing out there completely different.
To me, what's impressive is not the fact that he has a finger that's sensate and working as much as it is. What's impressive is that the other fingers are working so well.
Yes. This is the ideal. He did everything along the way, checked every box. I was hoping that one of the boxes wouldn't be checked so I could just do whatever, but he did a fantastic job, especially with, as you say, Chai, with other fingers, because his hand was obviously very swollen from the through and through gunshot injury. Okay, guys, keep going. Let's go. Good.
We're a little low on time. I can hit two kind of final. This is similar to the case you discussed, Harry. So just a different way to approach. This was actually an NFL wide receiver. We've talked about these. This is not the P-line, but we've got this impacted central fragment, PIP fracture dislocation, and kind of how the team would go at it. So to me, this is one that for me, again, gets consented for possible CRPP. There's a chance for an extension. If it wasn't an NFL receiver, extension block pinning and maybe a Strauch technique perhaps, but that impacted fragment worries me. More than likely in my hands, it's going to get a shotgun approach, ORIF with a hemi hamate on the consent as a backup. But I'm not sure what you and Jeff and Chai and others would plan on with this, especially an NFL guy.
Yeah, so I agree. ORIF versus hemi hamate.
Yeah, and so this is what I went with. So you can see this is our shotgun volar approach. We find our articular fragment. Usually a dental pick to me, you can tease off this kind of fibrinous layer and you can find that impacted piece and tamp it back up pretty cleanly. You can see a fairly anatomic reduction. And this guy, luckily, with the daily therapy that they get through the NFL, has a really good outcome. And asking about when people could play, that was a tricky thing with him. And so he did start playing at about a month.
How do you, maybe Becky or somebody, how do you, and we have just a minute more, how you're going to mobilize them in flexion, Glenn, or do you do Coban compressive wrap, or, you know, these first 10 days or 2 weeks are probably a little important, you know?
Yeah. So initially, after surgery, I just put him in a little the 10-degree flexion extension block, and then I had therapy make him a digital gutter splint and about 10 degrees of flexion, just mainly to prevent hyperextension, and let him do immediate active motion, Coban and edema control right away. When I first played him, I put these people into a 2-finger digital gutter where the next door neighbor is kind of helping it out. So it was a ring and small finger, 2-finger digital gutter. And then they go into a single finger digital gutter after that at about week 4.
Great, thanks.
And we kind of wrap it up with one little final case, a little twist on one that we all get a lot. So because this is a 35-year-old playing just flag football and has this closed injury. So we've got similar to like a pilon, but of the DIP. So we've got this obviously FTP avulsion fracture, but coupled with a distal phalanx fracture. And so how we go about it is sort of, I thought this was kind of a tricky one, because in part you think, well, I could always just pin it and then fix that piece, go Palmer, fix that piece with a little screw and just pin the joint. But obviously with an FTP repair, the whole goal is to get them going early in terms of your range of motion. So different strategies to deal with the combination injury like this.
Yeah, so little Volar plate, and a couple of the companies have like a little hook plate, or you can sort of make your own hook plate, and sort of palmarly, you're sort of on top of the FTP insertion, and then trying to, in a just barely bicortical fashion, because the germinal matrix is not too far from your dorsal fragment.
Yeah, I agree. That's exactly what I went with, Jeff. Same exact thought. So small little plate. That way we could get him moving right away. So got immediate range of motion. My therapist was happy about that. And just kind of the principles. We got anatomic reduction. We've got our axial and rotational alignment back, allowed early motion. Not a perfect outcome. You can see 10 to 65 at the DIP, but certainly I think so.
Pretty good, because, you know, zone 1 injuries have very often very little motion at the DIP joint. I've done a little twist to that. Go back to the thing is, I've actually taken a fairly hefty suture and drilled it from one side to the other in proximal to the germinal matrix, making an incision, a transverse incision over the dorsal aspect, and done a through and through U type of suture and tied it on the back over the extensor tendon. That links those two pieces together, maybe a small K-wire, and then a simple K-wire from the distal pulp into the dorsal segment, okay, to create the dorsal strut that they can then move against, because that's probably not going to move if the plate is not available, or if I don't think there's good screws. So I've done that a couple times, and I've been reasonably happy. And I cut that K-wire obviously below the skin at the tip, and take it out at about 4 to 6 weeks, probably 6 weeks. So the K-wire
case report on this, something like this, and what we do is a little low tech than what you did, Glenn. Just put interfract screws to restore the articular surface, but at the same time, through the tendon which attaches to the volar fragment, you take a crisscross stitch, like a Bunnell pull-out with 2-O-Proline, because it slides much easier, and then bring it out just past the lunula, so that it gets purchased in the distal fragment, and seems to be strong enough to allow early motion because it's 2-O-Proline. And then you just take it out. Just warn them about dystrophic nail. And that seemed to work remarkably well.
You tying it over a button, Chai, or just over the nail itself?
A fine button.
Yeah.
I've gotten away from that, Chai, because the nail is really bad.
But you got to go past the lunula. Otherwise, you'll get a dystrophic nail.
What size plate was that? Little 1-0 plate or 1-3 plate?
Yeah, well, I think 1-3, if I recall.
1-3, yeah.
What that is.
Yeah, looks beautiful.
Just kind of cut to fashion. It was one of these rail plates, and we just kind of cut it to fashion to fit.
That was originally one of the little ladder plates, right? It would have little pieces going up.
That's right.
Yeah, fantastic. All right, Chai, are you still there? Or wrap us up here. We have a few more things to go in the session.
Yeah, go for it. I think we've done good today.
Yeah. So we're going to really switch gears, but something we're all very interested in: flexor, extensor tendon injuries for soft tissue, and then wrap it up with the grand finale of the wrist. Scaphoid and the distal radius. So we have heavy hitters coming up over the next 4 weeks for everybody. So that concludes today's session. The link will be available in 24 hours on the lovely, brought to you by AO North America YouTube channel. So have a great weekend, everybody. College football returns to the Big Ten, so we're all excited.